This next section, I'm going to talk through two sets of differential diagnoses. First, the diagnosis among the 5 somatoform disorders, and then the differential between somatoform disorders, factitious disorder, and malingering. Put a star, whatever you do, to make an indication for this section, because this is a high-yield topic. Somatoform disorders, or the differential among the other disorders, appears in just about every exam. It's an obvious question to ask you, and one you should be well prepared for on the exam. There are 5 different somatoform disorders, and you should be able to recognize which one you're looking at. Now you remember, somatoform disorder is a result of somatization defense, overused, to borrow my metaphor again, way too many Oreo cookies here. Not surprisingly, the first of these somatoform disorders is somatization disorder. You're given the diagnosis of somatization disorder when the patient has 8 or more symptoms, all psychologically based but producing real physical symptoms. The physical symptoms are real, they are not feigned, but the etiology is psychic, not physiological. And you must follow a certain pattern. There must be at least 4 pain symptoms, 2 GI symptoms, 1 sexual functioning symptom, and 1 pseudoneurological symptom. Can you have more than 8? Yes. Can you have less than 8? Technically, no. You cannot have less than 8. Please note, the patient is not likely to have all of these 8 symptoms at the same time, and thank heavens, that would be outright debilitating, but you ought to be able to see them tracking back across the patient's medical history. We're trying to preserve this diagnosis, not for people that somaticize somewhat, but for people whom this is an ongoing, recurrent pattern of coping with the world. We're trying to hold on to this as a disorder, again, when it's something that is there repeatedly, repetitiously, beyond the person's control. Onset of somatization disorder must be prior to age 30. This is, again, not something you would develop as an elderly patient. And although this is not exclusive to women, much more common in females, and that's likely what you're going to see on the exam. 8 or more symptoms, entirely the result of psychological processes. Conversion disorder is our second option. Conversion disorder classically is a single symptom issue, but that doesn't have to be true. Classically, it's response to some sort of traumatic event, but that doesn't have to be true. What is true, it has to be loss of physical functioning, suggesting a physical disorder, entirely the result of psychological processes. Most common manifestations are loss of one of the primary senses, hearing, vision, for example, or loss of sensation or use of one of the limbs, hands, arms, legs, etc. Understand, the symptoms the patient has are real. They are unfeigned. They can't stop whenever they want to. They are just as disabled by the symptom as if it was actually some neurological problem. Now, how do I know the patient that presents with this conversion disorder, how do I know it's conversion disorder and not some as yet undetected neurological or physiological issue? Well, ladies and gentlemen, let's be clear, that's a difficult differential. It's difficult in the real world, but fortunately, you're going to find it a little bit easier to do that differential on the exam. In order to get the differential right, well, let's try to do this by walking through a concrete case together. Your patient comes in to see you and says, "Doc, I woke up this morning and I can't move my left hand. I don't feel anything, I can't move my left hand." Okay, now how do we know this is a conversion issue as opposed to some neurological issue? Well, the first thing we always want you to do is detail the exact nature and specifics of the symptom. So get out that pin and check exactly where the paralysis begins and ends. Let's say you discover it goes immediately around the base of the hand. Well, does that match what you remember from basic anatomy, basic neurophysiology? Well, here's a hint. If it doesn't match known physical structure, then it's likely a psychosomatic issue, don't you think? Secondly, we look for something called la belle indifférence in my worst French accent. La belle indifférence is the lack of the expected distress reaction. If I woke up tomorrow with my left hand utterly paralyzed, I would be greatly distressed. I would be concerned, upset. It would be a preoccupation that caused considerable arousal and discomfort. And yet your patient with that same symptom sits there calmly, unconcerned, saying, well, doc, what's for lunch? Doesn't that strike you as a little odd? It should, and this is la belle indifférence, which you should recognize as the use of what defense mechanism? Right, this is that deficit defense, isolation of affect. They're recognizing the symptom, but the emotional reaction is simply stripped away. It's not present. La belle indifférence is an example of isolation of affect. Now, before I leave talking about conversion, I need to cement a key idea. For conversion, and indeed all of these somatoform disorders, the person is not faking it. They truly are disabled by their symptom. And so, let's go back to our patient with a paralyzed left hand. Let's say I walk out of the office to take care of some errand, and the patient is sitting there in the office, and somehow things suddenly catch fire. And the only way the patient can save themselves is to use that left hand to open the window and operate the fire escape. Does the patient live or die? The answer is, of course, they die. Lose the notion that they can use that hand, quote, if they really want to, unquote. They're just as disabled, they're just as paralyzed as if we went in there and snipped the neurons. The only difference here is the problem is ideologically psychological, it's not physiological. And so the intervention must be to dealing with that psychological issue. Hypochondriasis is the third of the somatoform disorders. Hypochondriasis, a patient is convinced that they have some physical problem. They're convinced something's physically wrong with them. Most of us go through life assuming we're healthy until we receive evidence to the contrary. Hypochondriacs begin by assuming they're sick, they have some disease or syndrome, despite evidence to the contrary. They spend great time scanning their body, looking for simple signs they can elevate to be the symptoms of some horrible, maybe disfiguring disease. They're always talking about how the world is not safe, things aren't going to make you healthy, there's germs, there are things you're going to catch. Oh, and you have to be this way at least 6 months. Everybody gets hypochondriacal every once in a while. As you go through medical school, you probably felt this as you're sitting in pathology class. It's not a disorder when it's transitory, it's a disorder when it doesn't go away. So you think that you have a patient who might be a hypochondriac because you've run all the standard tests and found nothing. You can't find anything in the lab values, nothing in the physical exam, everything in your data looks like they're fine. So you're thinking maybe this person's a hypochondriac. Be careful. Because the research data says physicians tend to overdiagnose hypochondriasis by a 4-to-1 ratio. Whenever you run the standard test and found nothing, you tend to think maybe I have a hypochondriac. Well, it's possible, but it's more likely you just didn't do the right examination or didn't run the right test yet. So you think maybe the patient's a hypochondriac. What do you do? Well, the issue here is what's going on in the person's head. And so when you want to find out what's going on in somebody's head, you shut up, ask open-ended questions, and let the patient talk. And in that talk, as you're observing, you're going to see what you need to nail the diagnosis. Patient comes in with diffuse discomfort. You might say to them, well, I need to hear more detail from you, so tell me more about your discomfort. Well, says the patient, please notice my language here. Well, says the patient, it's this sharp pain in the left lower quadrant of my back, which radiates up into my right shoulder, and I have to sit down here. I'm a little dizzy. It's hard to get along because, well, I don't know how to deal with this because my children, they just don't visit me anymore. And at this point, you ought to have a pretty clear sense you have hypochondriasis on your hands. Notice you first get a generalization across the soma, across the body, and then once you break down the social sphere, you pretty much nail the diagnosis. Okay, now you think you have a patient who has hypochondriasis. I remind you, we do not refer these patients to psychiatrists. Why? They won't go. They're convinced it's a physical problem. They're insulted, they're angry if you suggest that it's psychological and ideology. You do not give them placebos. Why? They get really angry when they find out that you've given them placebos, which they will eventually. They think you're trying to fool them, you're disrespecting them, you don't care. What we want you to do is 2 things. 1, come up with a good palliative intervention, something that is recognizing that you hear that they're in pain, discomfort, etc. And then 2, schedule to see them again. In the ongoing relationship you will develop with them, you will learn what is motivating them, what is producing this belief system, these symptoms, and then you'll be able to come up with a way to address those symptoms. What do I mean by a palliative intervention? Well, commonly, the patient's complaining of pain, you might suggest that they use a particular heating pad. And my suggestion is the more detail you give them, the better. Don't say use a heating pad. Say, now I want you to use this particular heating pad. Let me write the brand down for you here. Some of them are crap, but this is the good one. The more specifics you're giving them, the better here. You want to maybe put them on a vitamin regimen. Not a bad thing for people's health, certainly given how some of us don't eat very well. Or half an aspirin a day, not bad for cardiovascular issues. All these things are real things. You can talk about what they do if people ask you, but they're just palliative, trying to show you recognizing the symptoms. In order to get the patient well, in some broad sense, you have to go where they are and then work with them with an understanding to lead them out again. Hypochondriasis. Somatoform pain disorder is fairly easy. This is conversion to pain. It's essentially a conversion disorder where the sole symptom is pain. We have a different diagnostic category for this because, well, pain is kind of a unique symptom. The problem is that pain is entirely subjective. There's nothing objective that we can see and measure here, entirely subjective. In order to get a diagnosis of somatoform pain disorder, the pain must be not a momentary or passing twinge, it must be severe, prolonged, and, crucially, must disrupt day-to-day life. This is not something that simply causes discomfort. This is something that becomes, well, prohibitive in terms of you doing usual activities. In short, we're going to nail this diagnosis by looking for secondary gain. Now, if that's a term you're not familiar with, let me clarify. Primary gain is what you get internally for having your symptoms. It's feeling better, relief from shame, guilt, remorse. These are primary gains. Secondary gain is what you get from the world around you. Attention, money, drugs, freedom from work or responsibility, all those are classic secondary gain. All disorders, even physical disorders, develop secondary gain over time. The person may begin to like the attention that they're getting from the doctors, nurses, and family. But it's a crucial issue even at the very beginning for somatoform pain disorder. In short, a patient who comes in to see you and says, "Doc, I have these migraines. They're so bad, it's all I can do to drag myself to and from work every day." Now, I feel sorry for this patient, don't you? But it's not somatoform pain disorder. Why? They're going to work. The presentation for somatoform pain would be, "Doc, I have these migraines that are so terrible, I can't even get out of bed and go to work anymore." That's likely somatoform pain. The key, severe, prolonged, disruptive, can't do usual activities anymore. We're looking for secondary gain to nail the diagnosis. Finally, we come to body dysmorphic disorder. This is a weird one, folks. People with severe body dysmorphic disorder may spend a long time, hours even, pressed up against the glass of a bathroom mirror, talking out loud, stream of consciousness, just about how butt ugly they think they look. Oh, his eyebrows are crooked, that nose is wrong. They just go on and on, stream of consciousness, just about how awful, horrible, and terrible they think they look. They're convinced they look hideous. They think when they go out, they should wear a mask or paper bag over their head, literally, so they don't scare young children. They think they shouldn't go out at all because why would they, be mean to people by making them look at them given how awful and horrible they look? Now, you look at them and, they may not look like a fashion model, but they're a reasonable human being. They're convinced they look awful. Often, this is focal on the face, but that doesn't have to be the only manifestation. I could think my hands are awful and misshapen, my abdomen isn't right, my genitals aren't good, my feet are misshapen. What it's not usually is a whole body issue. It's usually focused on a part of the body. Because of this sense of self as awful and horrible, the person can no longer do usual activities. They don't go out on social events. They may not be able to do a job where they have to be out seeing other people. They may be able in this internet age to do jobs without their home, but they're going to be isolated. They don't want people to see them and see how they look. If they have enough money, they may try to fix the problem. And these are the patients that go and get one plastic surgery after another, after another, after another. But, and crucially, the surgery never solves the problem. Because the problem is not how they appear, the problem is how they perceive. And changing what I'm looking at doesn't modify that perceptual mechanism. The singer Michael Jackson is felt by many observers to have body dysmorphic disorder. You can agree or disagree with that supposition, but I have to tell you, if you look at the before and after pictures of Michael Jackson, that's the kind of transformation we typically see for somebody who has severe body dysmorphic disorder. I saw a show, 60 Minutes, several years ago, where they were interviewing a woman who's in the Guinness Book of World Records because she's had more voluntary plastic surgeries on her face than anybody else in the history of mankind. If memory serves, 87 separate plastic surgeries. Now, they should have pictured what she looked like before. And all right, she wasn't a beauty, but at least looked like a normal human being. When they were interviewing her now after the surgeries, she was, I'm sorry, the oddest Mrs. Potato Head I've really ever seen. And she thought a few more surgeries should do it. They almost have it right. A few more surgeries should pretty much. Do you feel sorry for this woman? If I'm presenting this right, I hope you do. She has a severe problem and is in need of help and assistance. Oh, and by the way, the people that did those 87 separate plastic surgeries, we have a word we use when talking about them. The word we use is malpractice. Because I remind you, patients do not get to select inappropriate treatments. It doesn't matter that she can pay, it matters whether that's the appropriate intervention for her. Every plastic surgeon I know in the real world, once a patient goes in for the second or third plastic surgery, they send them to get screened for body dysmorphic disorder. And if they have body dysmorphic disorder, we treat that disorder, we don't do the plastic surgery. That's your exam issue. They're going to want the plastic surgery. If they have body dysmorphic disorder, not the right answer, you must treat the underlying condition. All 5 of these together constitute the somatoform disorders.